Welcome back to the PCA Deep Dive, where we take the big questions in spine care and unpack the evidence one study at a time. If you're one of the millions who've ever rolled out of bed and felt that sudden, sharp, low back pain, you've probably heard the familiar advice. Don't rush to get an X-ray, just wait it out. For decades, that guidance rested on the belief that imaging won't reveal much, won't change treatment, and carries unnecessary radiation risk. But today's study, published in MDPI, turns that entire consensus on its head. We're looking at research that compares healthy, pain-free individuals with people experiencing their first ever episode of acute mechanical low back pain. And the authors ask a bold question. Can a simple standing X-ray, the tool everyone is told to ignore, actually show objective biomechanical differences that matter? We'll break down who was studied, what was measured, and why their precision matters. Because the results challenge long-standing assumptions about alignment, pelvic mechanics, and whether imaging truly lacks value in an acute episode. So settle in. This one reframes the acute low back pain conversation in a way every clinician in Pennsylvania needs to hear.
If you're one of the, millions of people who have ever woken up with that sudden, sharp, low back pain,
which is pretty much everyone at some point.
Exactly. Then you've probably heard the standard medical advice. Just wait it out. Don't rush to get an X-ray.
Oh, absolutely. That's the consensus. And it's built on, decades of what's considered sound thinking.
Right.
For most uncomplicated first-time episodes, the guidelines say imaging probably won't find the cause. It won't change the treatment.
And there's the radiation exposure.
And you have to follow the ALRA principle, as low as reasonably achievable.
But the academic article we're getting into today, it basically takes that whole consensus and just flips it right on its head.
It really does.
So our mission in this deep dive is to look at a study that compared healthy, pain-free people to a group experiencing their first ever episode of acute low back pain.
And they're asking a really fundamental question. Can this technology we usually dismiss, a simple standing X-ray can, it actually show us measurable objective differences?
So what were the specific questions they were digging into?
There are two big ones. First, can the alignment of your lower spine, so how you're actually holding yourself, can that tell the two groups apart?
Oh, okay.
And second, does the underlying fixed shape of your pelvis, what we call pelvic morphology, does that explain why some people get this pain and others don't?
Okay, let's unpack that right away, because for years we've been told that defining a normal spinal curve or a normal lordosis is almost impossible. Why is that so tricky?
It's just so complex. I mean, your lumbar lordosis, that inward curve in your low back, it's influenced by your age, your gender, your BMI.
All these variables.
All these variables, and even how the image is taken. But the big one is that it's dictated by the physical shape of your pelvis.
Mm-hmm.
And because it's been so hard to find a consistent, measurable difference, between people in pain and people without, the default has just been, don't bother imaging.
So if this study is going to challenge that, they must have been incredibly specific about their setup. Who were the people they looked at?
They were meticulous. 100 people in total. 50 were the normal controls.
Meaning no back pain, ever.
No history of it at all. Verified clean. And the other 50 were the ALBP group. And the key for them was that this had to be their first ever episode of mechanical low back pain.
Ah, that first ever detail is so important, isn't it?
It's crucial.
Because it suggests this isn't some long-term degenerative thing. This is maybe an alignment problem that just got triggered.
Exactly. And the groups were matched on everything age around 28, balanced gender ratio. They were really trying to create an even playing field, structurally speaking.
Okay, so let's talk about the measurements. The X-rays were taken standing, barefoot, hands on the head.
Standardized positioning, yep.
We need to really focus on the two main angles they were tracking.
Absolutely. The way I think about it is like a shelf unit sitting on a foundation.
I like that analogy, okay.
The foundation is your pelvis,
Yeah.
and the shelf unit is your lumbar spine.
So what's the first measurement?
For the spine, for the shelves, they measured the lumbar lordosis, or LL. That's the global inward curve, measured from the bottom of T12 down to the top of the sacrum. A bigger number just means a deeper, more pronounced curve.
Got it. The curve of the shelves. What about the foundation?
That's the sacral base angle, or SBA. So imagine the top surface of your foundation, the sacrum. The SBA is just the angle of that surface relative to the floor.
So steeper angle.
A steeper SBA means the pelvis is tilted more forward, which then forces the lumbar spine to curve more sharply just to keep your body upright.
So LL and SBA, that's the alignment. But they also measured the basic pelvic morphology. Is that like the fixed blueprint of the foundation itself?
That's the perfect way to put it. Morphology is the inherent, fixed, unchangeable shape of the pelvis. It's what you were born with. It's the architecture that dictates all the alignment possibilities for you.
Excellent. Okay, methodology is clear. Now for the payoff, the results. This is where it gets really fascinating. Did the fundamental architecture of the pelvis, the morphology, did it differ between the healthy people and the ones in pain?
And here's the first big surprise. No.
No.
The underlying architecture, the pelvic morphology, was not statistically different between the healthy controls and the ALBP patients. They had the same basic blueprint.
Wait a second. So you're telling me the physical foundation, the pelvis, is basically identical in both groups. But one group is totally pain-free, and the other is in the middle of their first ever episode of intense back pain.
That's the pivot point of the whole study. The structure didn't explain the pain, but the alignment, the way the structure was being used, was profoundly different.
Okay, how different? Let's get into the actual numbers.
The LBP group showed what's called hyperlordosis,
An exaggerated curve.
a significantly exaggerated curve. Their average lumbar lordosis was minus 70 degrees. Now, compare that to the pain-free controls who averaged minus 65.4.
Wow. That 4.5-degree difference, that doesn't sound like a lot, but it's a huge jump biomechanically.
It's a huge jump. And what was driving that curve? The sacral base angle. The SBA was even more dramatic.
Okay.
The ALBP group had an average SBA of 44.5 degrees. The control group was much shallower, averaging 39.4.
So, to put it simply, patients in acute pain have a steeple sacrum and a deeper lower back curve. This hyperlordosis is the big finding, isn't it?
That's what they're hanging their hat on. Since the underlying structure was the same, the conclusion is that the differences are likely due to a poor fit.
A mechanical mismatch.
Mechanical mismatch. The way the sacrum was tilted, that steeper SBA created this exaggerated hyperlordosis alignment in the pain group. So it's not about having a structurally bad pelvis. It's about having a bad postural relationship between the spine and the pelvis.
And that is an objective, measurable difference. It just flies in the face of this idea that acute low back pain is always non-specific.
It does. And the SBA turned out to be a really powerful indicator. They ran a statistical analysis, and the SBA showed a reasonable ability to discriminate between the healthy and the ALBP groups.
Was there like a specific cutoff that came out of the data, a number that listeners could maybe remember?
Yes, there was. And this is a really key diagnostic nugget. They identified an optimal cutoff value for the sacral base angle, 41.2 degrees.
41.2.
That specific number suggests that if your SBA is greater than 41.2 degrees, you have the statistically high likelihood of showing that lumbar hyperlordosis that was associated with acute pain in this study.
That is a phenomenal piece of actionable data. Now, I do want to touch on a quick statistical note from the paper. The overall curve, the LL, was different, but it wasn't as good a classifier as the SBA. Why was that?
It really just came down to sample size.
Yeah.
The researchers calculated that, while their sample of 100 was big enough to validate the claims about the SBA, they needed a slightly larger group, maybe 144 people, to really lock down the Cobb angle as a standalone classifier. The difference was real, but the SBA was just the more robust metric in this specific study.
Got it. Okay, let's totally shift gears because now we have this objective evidence. We have hyperlordosis, we have a steep SBA, and it's associated with first-time acute pain. This brings us right to the controversy, right? The current guideline is no routine imaging. Why should we reconsider that?
Well, the authors argue that the basic reasons for avoiding X-rays are now challenged by this data. So rationale number one is low diagnostic yield.
Meaning the X-ray usually shows nothing useful.
Exactly. But this study proves the yield isn't low. There are objective, measurable differences. The imaging can reveal the specific alignment, the hyperlordosis, that could lead to a targeted treatment. It gets you beyond just generic advice.
So, counterpoint one, imaging has real utility. What about the idea that this is just a short-lived thing that will go away on its own?
That brings us to counterpoint two, the chronic issue. The source cites other data showing that a true one-off diagnosis of acute back pain is often wrong.
Really?
Yeah, up to 76% of patients who present with what they call acute pain are actually having a flare-up of a chronic structural condition.
I see.
So if a structural problem like hyperlordosis is causing consistent flare-ups, then getting that image early becomes even more justified to break that cycle.
And that brings us to the elephant in the room, radiation. This is what drives the whole A-layer principle. The authors here take a very aggressive stance against it.
They really do.
What's their specific critique of A-layer in the context of a low-dose spinal X-ray?
They argue that the whole ideology is based on something called the linear no-threshold assumption, or LNT.
Okay.
LNT assumes that any dose of radiation, no matter how tiny, carries some risk of causing cancer. And that assumption forces clinicians to avoid radiation whenever possible.
And the researchers here are saying that assumption is just flawed for this specific scenario.
They're saying it's not valid. They cite strong counter-evidence, arguing the LNT model simply doesn't apply to the low-dose range you get from a standard spinal X-ray. They argue that continuing this, what they call radiophobic fear-mongering, and delaying imaging based on an obsolete model is actually harmful.
Harmful because it stops the patient from getting a specific diagnosis.
Exactly, a diagnosis that could lead to effective evidence-based care.
So they're basically arguing that the risk of delayed or wrong treatment is greater than the tiny theoretical risk from the radiation.
That's the heart of it. It shifts the focus from, this general caution to gathering personalized information. If the X-ray gives you the key, the hyperlordosis, that unlocks the right treatment, then delaying it hurts the patient.
Which brings us to the practical application. So a clinician gets an X-ray, they identify hyperlordosis, they see an SBA over 41.2 degrees. What's the actionable treatment?
Well, identifying the structure gives you the roadmap. The source mentions preliminary evidence showing that this kind of hyperlordosis can be successfully addressed with targeted interventions. We're not talking about generic physical therapy here.
What are we talking about?
We're talking specific exercises, myofascial release techniques, and even things like lumbopelvic curve-reducing traction methods, all designed specifically to reposition that steep sacrum and reduce that exaggerated curve. The imaging results lead directly to a customized, biomechanically specific plan.
This has been a really fascinating dive. We've gone from these tiny measurements of bone angles all the way to a huge challenge of medical consensus. Let's try to summarize the main finding for everyone listening.
The takeaway is really clear.
Yeah.
In this sample, first-time acute low back pain patients had a significantly steeper sacral base angle and a corresponding exaggerated lumbar lordosis hyperlordosis compared to healthy people.
A measurable biomechanical signature.
A measurable signature of acute pain, yeah. And it exists independent of the underlying fixed shape of the pelvis. This provides strong, objective support for considering routine X-rays to get to a truly patient-specific management plan.
And that specific nugget we got was the sacral base angle cutoff of 41.2 degrees. If that can screen for hyperlordosis, that's a huge step forward.
It really is. And, it leaves us with a final provocative thought.
Okay.
This study, it identified the structural difference, right? But it lacked crucial patient data, like pain intensity, disability scores, or lifestyle factors.
Like their job or how active they are.
Exactly. So if we know an SBA over 41.2 degrees flags a patient for this kind of pain, what are the other factors? Their occupation, their BMI, the sports they play, that correlate most strongly with exceeding that threshold. Answering that could let clinicians stop X-raying everyone and instead perfectly select just those patients who are most likely to benefit from this objective information.
Targeting the right information to the right person at the right time. Thank you so much for walking us through this. We'll see you next time on the Deep Dive.
That wraps up today's deep dive. This study leaves us with a clear takeaway. Patients in their first episode of acute low back pain showed a measurably steeper sacral base angle and a corresponding hyperlordotic curve, even though their pelvic structure matched healthy controls. The difference wasn't anatomy, it was alignment, an objective biomechanical signature we can measure. And the practical benchmark is worth remembering. An SBA over 41.2 degrees strongly predicted acute pain in the study. These findings challenge the long-held idea that acute low back pain is always nonspecific, and that X-rays have low diagnostic value. They also raise fair questions about whether outdated radiation assumptions are preventing patients from receiving accurate and timely care. Thank you for joining us for this PCA Deep Dive. Stay healthy, curious, and informed. If you are not a PCA member, consider joining, supporting the PCA PAC, and sharing this information with your patients and legislators. For PCA members, a full infographic is available on the PCA website. Please like, subscribe, and follow for future deep dive episodes. We'll see you next time.